One, we've heard an awful lot around what needs to happen. My question really is, what's the biggest barrier stopping us? And how do we overcome it? So I'm going to start with Chris on the end there. What do you think is the biggest barrier that you see? And what's the solution?
Perhaps fatigue in the system at the moment. The system is under a lot of pressure. The headroom to think about what a brighter future could look like while the attacking the acute ones. But I think the story that we've heard today is compelling. If anybody's in any doubt why we should shift care from the walls of the hospital into patients' homes, focusing on prevention, the case is compelling. I think that's a really exciting opportunity to create sustainability. And I think that we just need to hold that belief. I think we continue to work in geographical silos, we work in budgetary silos, we work in perhaps professional silos. I think opportunities like today break down some of those barriers. We have a strategic opportunity through Community by Design to say that this is where we need to move. And I think we just need to embrace that. And I think stories like what we've heard today and other specialities can show the system as a whole that this is entirely possible. And I just think that we need to hold that faith, recognising that post-pandemic, post-austerity, all of these things have got pressure on the system are the reason why people haven't got the headroom. But stories like today are inspiring, and I think if we hold on to that, I think we can see the shift that we do need. And there will be material shifts needed in where resources are, from when we treat patients to where we actually allow them to live well as well.
Thanks, Chris. Can we move here?
Fantastic. So just building on Chris's points, I think from my perspective, the thing that's one of the major challenges in the system is the waste, complexity and bureaucracy that exists in the system. And it gets in the way of the efficient and effective care we know we can provide. And what I see from our perspective on a day-to-day basis is we continue to add, and we don't look at what we should be moving to streamline and make our efficiencies and our care more efficient and of higher quality.
Very pragmatic comment from me, really. I think it's really hard with the financial pressure that the NHS is under to shift money into something that's not going to deliver immediately for you. That's not to say that we haven't done it, because we have, but that does require, because of that pressure on the finances, I think, people to be brave and to know that it's the right thing. And I think cases such as FLS, which is incredibly compelling, I think helps build that case for that shift. It's great to see Tracy's in the audience for us as well. And we joke often, Tracy says, give me a couple of million quid, let me show you what I can do with it. It's very modest in the grand scheme of things. I honestly, truly believe we've got the resources to do this. We're spending it in the wrong way. But that does require bravery and boldness to say we're not going to do what we've always done, we're going to do something different. But here is what we will deliver for you instead of that, because it's the right thing to do. So I think the barriers are at that immediacy of finance and that brave step, I think, to take.
Thanks, Leanne. I think, again, you're absolutely right. For those of you who are unaware, the Welsh budget, when it was devolved first, was 35% of the total budget. It's now 55%. How much higher can we go and take it away from other services and support? And again, the work the Commission has done is looked at. There's huge amounts of resources out there. It's just we're not using them in the most effective and prudent way. And we really need to get our heads around that. And I think it was a previous speaker said how good we were at waste. That was managing waste, wasn't it? We've estimated in the health and care sector in Wales between 20 to 30% of the resources that we have are wasted. That is morally wrong. We really have a big issue to look at very hard at what we do with the resources we have available to us. And that's not just about empowerment, it's about people, it's about expertise, and all the other. Can I ask us, our trainees, what's the issue?
Is it for us?
Yes, it should be. observations as a trainee? What do you think is the biggest barrier for you?
To be honest, it should be for everyone. Like training opportunities to be given to everyone, and it's personal opinion. It's a personal thing how much they want to get out of the training. It's like individual to individual basis. Somebody wants to develop into something maybe going for the medical training. Somebody wants to go for the GP, and along with that other commitments in their life. So it might be possible for someone to do a lot and someone maybe little, but everything counts.
Chika, do you want to add your observations? What do you think is the biggest barrier?
Yeah, so I think we don't really get much exposure to the idea of services like this. I didn't know FLS was a thing until I started this project, and I'm sure there's other services similar to this that exist out there. And we need to know about the foundations of these so that we can possibly make ones like this in the future when we're working. And I also think that, like I've mentioned in my talk, we do need more time in clinics, and when we're in clinics, I think it would be very helpful if we're able to speak to patients, not just be sat in the corner. Maybe we don't have to take up more of your time. We could go into a separate room. If you have a patient that you know would be good for us to speak to, just encourage us.
Just to add on, I think the earlier the opportunity to learn, it's better because we are kind of a blank sheet. So whatever opportunities are given to us, we'll grow on them. So I think earlier it is, the better it is. Thank you.
Thank you very much. That's really interesting and thought-provoking comments. Let's open to the audience. What do you think? This is your last Q&A session for the experts. Put your hands up. I've got a few questions in the back of my head I can put in the corner. Rosemary.
Thank you very much. I just wanted to pick up on your comments about teaching and long-term conditions. So at the Aberdeen Medical School we have a series of horizontal themes across 4th and 5th year, and one of them is long-term conditions. But in practice that doesn't work. The focus is very much on the acute front door, and our students do not get exposure to managing long-term conditions and some of the challenges that entails. I don't know whether you want to add anything.
I'll just add, having done a training program for whole Wales for 10 years, we have managed to introduce clinics mainly for all our trainees, and it's mandatory. But still what happens at the end? Not every trainee able to get to the clinics, and that's what we have to do. Any education supervisor sitting in the room, they have been harassed for me at 80 clinics in 3 years. But that's not enough. We're talking of so many clinics, and they need to be starting at the medical school level. Year 1, go to the clinic, continue the journey. Foundation, go to the clinics. And they're not able to expose to the chronic disease management. Go to the GP, primary care. So I think we need to change some of our ways and also how we train our next workforce. That's what is needed. Thank you.
Okay, so, question on that.
So it is not a question, it is a comment to Dr. Hossain when she asked about the lab observation. I'm one of the trainees currently in the medicine training year 2. I just want to make a comment here that, as my colleagues in the panel said, it is the resistance I observed is the resistance to change. Our senior clinicians are so much over-occupied with their clinical commitments. Although our education supervisors, as Dr. Singh is aware that education supervisors, they do get some free time in a week or for a month to supervise their trainees. But how many times that time would be utilized in the clinical commitments which the clinicians must end up doing because of the unnoticed work other than their clinical commitments that is bombarded on them. They don't have that much time. They don't have that much free time to give some ideas, to take the projects forward for the trainees like me. So considering that, although the overall system is stretched, but there is, even someone bring up that as a trainee, if I bring up an idea that we can do something, we can change. And firstly, there will be lack of supervision to design that new thing for the better health. And if there is any, there will be resistance from like a clinician, junior level to the senior level from the management, and it will end up having no funding to support that project. That is my observation. Thank you.
It's a very interesting observation, and I think it's one that we are well aware of. We link very closely with, if you like, our clinicians of the future. How do we? I think we give them about 2 or 3 years before they become institutionalized in the way of thinking and doing that we have currently. How can we ensure that we take the points that you just made and help combine that new enthusiasm, those new insights and experience coming to the table alongside, if you like, the more experience? And I think there's a real opportunity there for that to be supported and opened up.
Yes, I mean, that was actually one of the questions I was going to ask Chris and Tom. You've got a tension. You've got an overwhelming clinical situation where there's too many patients to be seen, and then you've got all these health innovation and time to implement, and you can't have both. That's just what it is. So I think we invest and say, as part of routine nurse, pharmacist, medic timetable, you have rigid, protected time to do your job better, or you don't. And if you want to improve, you have to embed that time in. I've never seen an FLS nurse job plan that says every 2 weeks you have an afternoon off to do pure leadership and quality improvement. Unless you do that, I can do it where I work because I enforce it, but unless you do that at the national level, it won't work. Because you will never be able to stop what that trainee said, is the unstoppable clinical onslaught of too much to do. But unless you make that at a very high level, trickle down, you have to see fewer patients so you can do your job better. That has to be a 101. And it'd be great for Wales to do it, because then we'll copy and England. It's easy for me to say it, but from my observation, that has been the biggest barrier. You have all of these, you can set up new services. I don't know how much in this time is brought up, but it's not fully recognised as a job. It's always seen as a cherry on top. See your 1,000 patients or 100 patients as a cherry on top to improve your service, where it should be the other way around. You should improve your bloody services, because he wants every penny to count, and he's not going to make every penny count unless you've got time to improve. But unfortunately, and I understand the COA's position, they have to meet government deadlines and tariffs and stuff. That's a bit
Thinking anything in particular, but it's just, I just open it up to the audience. Tracy.
You're getting your steps in, aren't you? Thank you. A statement and a question. So Tracy Daskovich, Director of Public Health for Went. I think my statement is that in terms of the point, in terms of the tap being turned off, how do we manage that demand and how can we get ahead of the curve from a preventative medicine perspective to enable us to have the headroom to do that? My observation is this: I've been in the Welsh system for 3 years. We do not utilise public health. In fact, I would go as far as saying the system doesn't understand public health. It certainly doesn't understand local public health and the role of the Director of Public Health and his teams. So we have a structure of a national organisation, and then each health board has a public health team within it, and we are not utilising that resource, we're not understanding that resource. So I think there is something in that we need to start and use public health effectively, because we can do some of that work alongside our clinical colleagues to enable that and do things differently. So that's an observation and an offer, I suppose. Use us, we're here, and we are not being utilised. So that's your point. My other question is to registrars. In terms of your training programme and your capacity, how much opportunity do you have to do the tiers of prevention, so primary, secondary and tertiary, and then to feed that into preventative medicine practice? And within that,
about how AI has been implemented in identifying cases of fragility fractures I'm just wondering if it could be suitable for, if it could be something that could be applied in the future for identifying, in regards to primary prevention, people who are at risk for secondary osteoporosis, in the GP record, if we use AI, to identify which patients would be at risk. It's just a thought if it's possible for the future. I don't know if it's something that would be doable. I don't know. I just wanted to get your thoughts on these.
It's already been done.
Oh, is it?
They'll be bringing coming to your hospital soon with a very big bill. They're already doing that.
There we are. There's the answer to your question.
Thank you.
Can I draw this session to a close? And before I hand over to Evelyn, can I just make some observations, really? We have some great opportunities here, and we've heard them all today. We have great opportunities to ensure that we have great value and be very much more prudent with the approaches that we have. We have to make sure that we have the right services, they're integrated. We must make sure they are proactive, not necessarily just reactive. And we must ensure that we are looking at the system flow from a patient perspective, but also from a system perspective. We've just published our system flow paper, which clearly indicates we are even more fragmented between systems, and we don't look at the impact of one part of the system on the other. So there's loads to do, but what a great opportunity to use FLS to prove the point here. We've also heard about the power and the importance of leadership and collaboration. We won't achieve this alone. It won't be those single lone leaders that will do it. We must find and get that collective, if you like, energy and motivation. And we are seeing that and feeling that in the room today. And we've heard about adoption and spread. Got great ideas in us. How do we escalate them rather than remain in isolation? And as was said, small gains lead to substantial benefits. Really important also that we never forget the patient perspective in this. This isn't about doing things to people, on people, for people. It's with people. And we must remember to look at it through the eyes of the people that we're there to serve. So in conclusion, before I hand over to Inda, one of my most favourite sayings is, before you leave this room, just give some thought to this. The world will not be destroyed because of the world conflicts and everything else we see. The world will be destroyed by those who stand by and let it happen. But please don't be one of those that stand by and say, well, that was nice, wasn't it? And carry on doing your day job. Please think about what you can do and what difference you can make, because you can all make a difference in your own way. Thank you very much. And